Hello, everyone. My name is Lindsay Brown from Beyond Clean, and joining me from the Beyond Clean team is also Lisa McCowan today. We'd like to thank you for joining us for this seventh in an 11-part collaborative webinar series between Beyond Clean and Censis Technologies. This month, our True Grit series is focused on leadership. A good leader is a person who applies the positive characteristics of grit to bring out the best in everyone they work with. This month, Censis actually wants to give you the opportunity to recognize the healthcare leaders you know to be on the lookout for more information on how to nominate your favorite leader coming soon. If you haven't joined us for a Beyond Clean virtual event, I'd like to call your attention to a couple of features. On your screen, you'll find a list of resources put together by Censis Technologies. These resources will allow you to access some additional content. There's also a Q&A tool on the left-hand side of your screen down toward the bottom where you can submit questions for the speaker throughout the presentation. Those questions will be addressed during the end, during the question and answer portion. You will also see along the bottom of your screen a row of icons, and one of those icons has thought bubbles on it. That's the group chat feature where you can interact with both the speaker and other attendees today. We often think that leaders are loud. They boldly walk in front, they see and want to be seen, they direct directly, they drive the driven, they rule. But so often leaders are the complete opposite of this image that we've created. Often true leaders love that others find the courage to walk in front while they steer from behind. Often true leaders see but don't want to be seen. They hear and they listen, but they don't want to be heard. Often they're subtle, guiding through suggestions, not drive, seeking for others to succeed. Whether you have a great working relationship between the OR and sterile processing in your facility, or whether or not there's room for improvement, this conversation today with Vincent Sanchez is one that you're certainly going to be glad that you tuned in for. So with that, without further ado, I'd like to turn it over to our speaker for today, Vincent Sanchez.
Thanks, Lindsay. Good morning, everyone. I've been sitting here refreshing the attendee list, looking at all the different hospitals across the country that have logged in. It's really neat to see so many people from so many different facilities that are here to listen to me talk about my experiences as an SPD technician and the things that we did to improve our own hospital's relationship between our department and the operating room. So background about me, I worked at the Memorial Hermann Health System for 6 years. I actually started in sterile processing when I was 17. I worked in the kitchen at a small hospital in my hometown, Abilene, Texas, and my dad was the lab director there, and he knew I hated working in the kitchen. The OR director was like, "Hey, we need a SPD tech. You think Vincent would be interested?" And he was like, "I don't know, go ask him." So she came and found me and was like, "Hey, have you ever thought about working in sterile processing?" And I was like, "I don't know what that is, but I'd like to do that instead of cleaning ranch dressing out of buckets," which has scarred me for life. But that's another topic for another day. So I got into sterile processing at 17, worked there. We moved to Houston, worked at another regional hospital, and then eventually went to Memorial Hermann. And one of the things that has made me sort of passionate about the relationships between SPD and the OR is that when I got to that hospital, we didn't have a really great relationship with the OR. There was lots of animosity, lots of back and forth blaming, all the stuff that anyone who's worked in SPD for a long enough period of time is familiar with. And really, while that's hard on the employees, it's hardest on the patients, because when things aren't being done efficiently and people aren't communicating, that's who it really affects. So that's what kind of drove me to work with the management team at my hospital and put together some initiatives to really work on improving that. So with that being said, I've got a couple questions to start, a couple of poll questions to start, just to kind of get an idea of how many OR and SPD technicians we have, and then what your role is in that department. So we'll start up the first one. What department do you work in? So on this slide, there are radio buttons. You can actually click on the slide, and then once you make your choice, just go ahead and hit submit. So we'll give about 20, 30 seconds for everyone to pick their department, and then we'll see the results. We'll find out how many people are going to be mad at me today. Just kidding. And I see we had some people log in just now at 9:05, 8:05 for me. We're doing a poll question, so if you want to go ahead and select what department you're in, you can click on the slide and then just hit the submit button. We'll check that out in just a second here. So, all right. All right, lots of sterile processing people, which is great. Sterile processing is the heart of the hospital. So on the next slide, I've got a question regarding your role in your actual department. There are a lot of these. I hit all the high points. So if you're looking, particularly if you're in the OR or in a different department, yours is probably near the bottom, so you may need to scroll. But just like the last slide, hit the radio button and then hit submit. You will have to scroll to reach the submit button. Oh, there's Jake McHugh from Mayo. I see him in our True Grid app a lot. All right, let's check out these results. Oh, awesome. Team leads and managers. All right, so we'll go ahead and get into the meat of the presentation. Hi, Jake. I saw your Q&A come through. Okay, and we have a director of both departments. All right. I work with a couple of directors from hospitals in Houston that manage both areas, so even better. So the things I want to talk about today, we want to look at the relationship between the two departments, talk about the methods we use to improve those relationships when I worked in the hospital, how to solidify that, and then look at how a powerful, good relationship between the two departments benefits patients and patient care. And then, like I said, just look at a couple of methods to improve and maintain that relationship that I found really valuable. You guys, I'm sure it's nothing new, but it's always good to reinforce and hear about it again. So, one of the things that I heard when I worked in sterile processing a lot was, and really the worst part was that I heard it from my fellow SPD techs that, we weren't as good as the OR, that, they had all this education. We just had our certificate. They felt like the OR knew that and kind of passive aggressively pointed that out to us, which of course, it makes you resentful. And when you're resentful, you're not the best employee, the best technician that you can be. And then, as we all know, SPD itself it's one of the most critical departments in the hospital. The OR can't run without SPD, but at the same time, SPD can't run without the OR. We need each other. And I think I was telling Lindsay and Grace the other day, I said, for me, that's where the disconnect always was. It was the disconnect between the department that the OR relied on and the department that SPD relied on. Because while we always say, well, SPD is the heart of the hospital, OR can't do their job without them, we can't do our job without the OR. If it wasn't for surgery, there would be no SPD techs. So, while they're both important, they both need each other as well. And that's the last point on that slide. Both departments working together creates the best possible patient outcome. And that's really what we're all in this for. So that's what's most important. You have to work together to get instruments where they need to be, get the surgeons what they need, all that stuff to ensure that when someone comes to the hospital, they leave in a better condition than which they arrived. So that's that. And as we've kind of alluded to, negative relationships, it generates resentment in both departments. When I first started working at my hospital, like I said, we had a really negative relationship. We had, we were short-staffed in SPD, which meant we were all tired. We were all working, longer than 8 hours, 10, 12. We had one guy that worked like 16 hours so many times that they actually adjusted the call pay schedule because they were having to pay him so much money. But, so that's hard, and then you have the OR doing their, all their cases. They were short-staffed at the time, not as short-staffed as we were, but still short-staffed. So, they needed things, and they needed things now. They didn't have time to wait. We didn't have enough people to get them what they needed right away. So it really damaged the relationship that we had because, everyone wants to feel like they are a priority. And, the fact of the matter is there's only so many resources for so many priorities. But, when that kind of stuff happens, you end up feeling, you can cause the SPD technicians to feel undervalued and not respected. And then the OR, in turn, a lot of times I think feels like SPD is not fully invested in patient care, which for the vast majority of technicians, I don't think is remotely true. So say that. So the most important part of fixing that, of course, is opening pathways to communication. So right there, we have some examples of what happens when, or at least in my experience, what happens when the departments aren't getting along. So in mine, because we had technicians that were like, the OR doesn't care that we're short-staffed. They don't care that we're back here, for lack of a better phrase, busting our asses getting this stuff done. When mistakes were made or we needed help and we couldn't get it, or there was little small issues, they just didn't get addressed. We were like, we were too busy. We didn't have time. We didn't want to hear about it. We were just working to get out what we could get out. I remember coming in one day and seeing a stack of containers that literally went from a table to the ceiling. And it can be disheartening to have that amount of work and not enough people. And then to have the OR staff coming in, asking for things and wanting to know why things aren't done. It's tough. It's really tough. And there's times when it's tough to get up and come to work the next day. But, hopefully, yeah, exactly, Kevin, exactly. But, the good news is that I've kind of alluded to how the story ends in that we fixed so many of these things. And by the time I left this hospital, we were in such a better place, plenty of staff, we'll get to that. I don't want to get ahead. But, that's one of the things is without that communication, without that camaraderie, and without the kind of mutual understanding, it's easy for one department to look at the other and say, well, you have no idea what I'm dealing with, and you don't care. So, I'm just here for me. I'm here to get my paycheck, and I'm here to go home. And when that happens, you have, like right there on the slide, and I've seen this happen. Well, I know the set was incomplete, but there's 10 other ones. Just go get another one. And then, it's never really addressed. Okay, well, why was it incomplete? Why was it put up that way? What can we do to stop that from happening again? And then, the next one, I'm sure we've all heard this. I've said it before. I'll admit that. Someone comes and says, well, I need to help find this. I need help locating this tray. I'm like, well, I'm busy. I can't help you with that right now. And, looking back as the number one, the type of employee I am now, and number two, someone who's worked in the field long enough to know better now, I should have those words should have never come out of my mouth, because at the end of the day, I wasn't saying that to the OR person. I was in the moment, but really who I was saying it to was the patient. I'm too busy to help this person find what they need to help you. And that's not okay. uh, stuff gets broken, and it's just like, well, put them back right, and it won't get broken, which is true. But at the same time, if we had that pathway to communication and the ability to talk to the people in the OR, and the OR had the ability to talk to us, we could address what's happening that's causing them to not be put back. It may be an issue with a particular staff member, or it may just be that the way that we have them set up, or the way that I know there's outside pressures like turning over rooms and things like that. It may just be outside things that are causing these problems to recur that don't get addressed because no one's talking to each other. And then, of course, everyone knows what happens when things get particularly negative. You have people start leaving, which not only affects each department, but it affects patient care. It affects the hospital's finances. You have to hire new people. You have to train new people. You have to start all over. And no one wants that. So on to the next slide. And let me just stop for a second and say this. I see a couple people typing group chat. So one of the things I like to do when I do these types of presentations is I like to have a conversation with you guys. So if you guys, there's something I'm saying that you disagree with, you agree with, you have questions about, drop it in group chat, because what I really want to do is I want to hear from people from all over the country. I worked in one hospital in one city, and my experience is my own, but I'm sure it's not the experience that all the rest of you have had. So please feel free. I encourage everyone to use group chat. I'm a millennial, so I'm into the Twitch streaming and Discord and all the online stuff. So I will watch that and respond if anyone has anything to say. Larry, I saw you said sounds like your department, and Kevin, it's very common. That is true. It is more common than it should be. And Larry, if that sounds like your department, hopefully some of the stuff we're going to talk about in a little bit, you can take back and make some improvements. So we'll get on to the next one here. So it's stuff I've been saying. So without a pathway to communicate, no one gets along. Everyone's resentful of each other. Lots of resentment and stuff. But on the other side of the coin, positive relationships. So what do you get when you have a positive relationship? You have people that work together. You have OR staff and SPD technicians that work together to get sets and inventory up that are needed for the next day. You have the ability to, work together to streamline your trays, streamline your inventory, and you really provide optimal patient care when everyone's on the same page. And that was one of the things we built, which we'll see in a little bit. But the key is, once you have those communication lines, you have both departments working together to find solutions to common problems. And, like I've said already, it doesn't get better than that. So how can we build an effective team? So one of the things that I see as I work in my different hospitals is hospitals that are trying to, they're in the process of building this relationship, and they keep running into, we move forward, and then we take a couple steps back. We move forward, we're going to take a couple steps back. And the key there is management, team leaders, and coordinators. When you get team leaders, managers, coordinators from both departments fully invested, that's really the key to moving forward, building the relationship, and maintaining it. I've seen, too many cases where, we're working on OR reporting, we're working on different initiatives to get the departments in compliance with one another and compliance with infection control, and one manager or one team, one department kind of falls off the wagon a little bit. And it's because we need support all the way up, leadership, staff, everybody. We need full investment from the entire team. So the example there is the Memorial Hermann the Woodlands Ironman orthopedic team. What that was we put together a team, so a little bit about the Woodlands. It's a community in Houston, master plan community, lots of athletes, lots of triathletes. I live in Texas, so of course football, sports, everything's a huge deal here. So we do a lot of orthopedic cases. Every day on Monday, we had Ortho Monday. 10, 12, 15, 20 total joints, just back to back to back to back to back. Big day for orthopedic cases. And that was one of our biggest pain points, was when ortho cases were going, there wasn't always good communication. We would, stuff wouldn't get turned over, drills wouldn't get turned over. And we'd end up having to, I'm going to use the bad word because it's easier to say, we'd end up having to flash things, which, that's not ideal for patient care. So yeah, ortho is my favorite specialty for sure. So what we did was we established what we call the Ironman team, which is named after the Ironman triathlon. So big marathon happens out here in the Woodlands every year. Shuts down all the roads. It's really great for traffic, but it's a really cool event to watch. So we put that together, and what we did was we had staff from the OR, we had managers, we had the OR manager and director, we had the orthopedic coordinator, we had SPD manager, and me as the orthopedic specialist on the team. And I would come in every day, and we would cycle through each room, talk to the doctors, see if they had any issues. If they had issues, we'd make notes, and then after the cases were over, if we needed to talk to them, we'd talk to them. Otherwise, we'd get with the ortho coordinators and the nurses and scrub techs that were in each room, and if there was anything that needed to be addressed, we'd address it right there and then. And as the tracking system coordinator for SPD, I was able to go in and develop solutions and streamline trays and get the doctors what they needed, and it really helped. So we'll talk a little bit more about that later, but I'm going to go on the next point because I've seen some people bring it up. So when the teams are working together, another key is demonstrating the value on both sides. SPD staff see the criticality of their work, and OR staff see the knowledge and skill required to work in SPD. I think both of those things are very often underestimated by each department. SPD, especially with the move towards minimally invasive instrumentation and surgery, the instruments have gotten more and more and more and more complex. And the knowledge required to clean and disassemble, clean, reassemble, in some cases, sterilize and maintain those instruments has gotten, it's become more extensive. There's more stuff you have to know now to do your job than you did in the past. And then on the same coin, I heard staff when well, there's 24 Rubios in this tray. What does it matter if we don't put up 2 of them? So there's the OR doesn't always understand what it takes to work in SPD. By the same token, SPD doesn't always understand what it takes to work in the OR, the decisions that are being made, and what it's like to work on a living human being on the table. So I saw someone point that out in the group chat. Pete, the last statement: mutual respect and understanding allows everyone to invest in providing for the people that matter most, the patient. And that's the key, and that's really what we're trying to drive is, when you build these teams, you build these communication pathways, you work together, you put faces to names, you encourage people to be in different departments. That's what really and truly drives patient care, and it allows you to develop that mutual respect, and it allows you to provide for people that matter most. So let me read through the group chat here for just a second. Teresa says, I'm with supply chain management, and the OR used to set up a surgery without having all they needed for the surgery, and then would blame us. We told them to stop setting up surgery knowing they did not have all they needed. When they did, we started working together, and now we're getting along great. That's awesome. That was one of the things we worked on. I think that's a very common problem all over the place, is there's just not enough inventory for the cases that are being done. And, the OR, doesn't always understand what it takes to work in SPD. By the same token, SPD doesn't always understand what it takes to work in the OR, the decisions that are being made, and what it's like to work on a living human being on the table. So I think that's a very common problem all over the place, is there's just not enough inventory for the cases that are being done. I'm assuming similar to your hospital, we set up coordinators on. I worked on the second shift, so we set up coordinators on my shift and liaisons in the OR. And when we came in at 2:00, number one, we'd sit down and we'd go over the schedule and see what was needed for the next day. So we had an up-to-date priority list. And then as the day went on, we would take time to meet with those coordinators and our liaisons and review the cases for 7:30 for the next day to make sure they had everything they needed. And if they didn't have something they needed, we'd add it to our priority list if it wasn't there, or we'd push it up toward the top to get it done as soon as possible. So that's good. That's a big pain point, and that's great that y'all have been able to work that out, and everything's moving along. And then Tricia said, most of the time the OR is now using the sensor track messaging to request items for reprocessing. Works great when used for sure. Yeah. So my accounts are using our other product, Maestro, and we have a similar feature for staff in the OR to report back to us when there's an issue with inventory, or they need a change, or something's dull or whatever. And using those functions in your tracking system so that you can communicate from department to department. That's definitely a key, because number one, it gives you a bit of a paper trail to kind of see what requests are flowing from a managerial standpoint, who's asking for what's being asked for repeatedly, which, as we all know, when you need capital to purchase trays, or you need funding, the finance officers at the hospitals, they want to see a piece of paper with, you can't see my hand. They want to see a piece of paper with numbers on it that says exactly why you need the money that you're asking for. So, using those tools and using the data at your fingertips to justify what you need that's another key. And I'm glad that y'all are able to make that work and get what you need. And then Pete, main focus, always patients, 100%. Sometimes, like I was saying at the beginning, when you're short-staffed and everyone's working hard to get stuff up, I think sometimes it's easy to lose focus on that. But, at the end of the day, that is who we're all working for, is the patients. So some of the methods we use to build an effective team, like I said, I'm sure this won't be anything new, but we made time to allow our SPD techs to observe cases that they were interested in, and that, we could get the doctors and stuff to agree to let us watch. So, like I said earlier, orthopedics, huge thing for me. Love it. Think it's really cool. I actually have, no one can see it, but on this, back there is a external fixator off of a leg that was left behind, and I made it into a desk ornament. And then when I left, they let me take it with me. So it hangs out back there as a reminder of my time as the orthopedic specialist. So, I made it a point when I had the opportunity to go watch cases and meet surgeons and observe what went on in the OR. And for me, what it did was it really showed me and reinforced for me how important the work I was doing was, and being able to see the decision-making process, and how even those little small things, like I said earlier, there's 24 Rubios, they'll be all right if they have 22. Sometimes those little small things become much larger things. And if you've never gotten a chance to go to the OR and observe and see the surgeons work and how they work with their team in there, it's really eye-opening. And I was really glad that I had the opportunity to go do that. I got to meet some really cool doctors, and saw some amazing things. Saw people with bones that I was like, I don't know how you're going to put that back, and they put it back, and it's just mind-boggling sometimes. But like it says on the slide, it gives the people in SPD an opportunity to see how their work is actually affecting patient care. And I think when you see that, it really encourages you as a tech, at least it did for me, to invest fully in your job. And then having the OR staff come work in SPD with the SPD team. Like I alluded to earlier, we've got an increased number of minimally invasive surgery, an increased number of minimally invasive surgical instruments that are becoming more and more and more complex. So having the OR come in, seeing the SPD staff work, maybe even helping them work, helping them to assemble trays, it really, I think, drives home for them that it's not just standing back there reading a list and putting things in a box. There's a lot of knowledge and a lot of skill that goes into properly disassembling, cleaning, sterilizing, and packing those sets so that they're ready for our patients. And, it all drives home what we've talked about all along, further cements the understanding between the two departments. So Kenya, add-on cases can also present an issue when it comes to the availability of instruments. Oftentimes cases are added and SPD isn't informed in time enough to turn over the instruments, turn over the needed items. That's true. And that was one of the things that our liaisons were responsible for, was when the schedulers put up a case, they would notify the liaisons. The liaisons would come up and say, hey, just so you guys know, this wasn't on the schedule earlier. It's on the schedule now. This is what we're going to need. You guys have this stuff ready. If not, we make it ready. And just, like I've been saying, it all goes back to communication, and having that communicative pathway, it helps make sure that priorities are prioritized correctly. So, maybe that's something that y'all could implement at your hospital. Maybe you have, I don't know. But it just gives the staff enough time to react. As far as not being informed in enough time to turn over the instruments, like I said, having the liaisons, I think that's a key. I think it was a key point for us, and I think that would be really beneficial for y'all. And then Julie, having our OR staff work in the SPDs made a huge difference. I agree, 100%. When they came back and saw what we were doing back there, and that it wasn't, like I said, that it wasn't just counting to 4, it really helped a lot. And it also helps, I think, too, especially in larger hospitals where SP and the OR may be on different floors and they communicate most of the time over phone, or through, like I said, like the liaisons through a couple people. I think going there and putting a face to the name, and SPD going to the OR, putting faces to names, that really helps. Humans, I think we're visual creatures, and, it's like we see all the time on the internet. People say things and do things they wouldn't do because they feel anonymous. And when you have a face with a name, and you have a relationship with that person beyond just talking to them on the phone, it softens the blows when there's issues. And I feel like it makes people more willing to work together because, they're like, oh, I know Vincent, he works down there. I don't want to, yell at him, which I got yelled at, but whatever. So that's, going back to what you said, I think that's great. Rajan, I hope I said that right. Rajan, most of the OR staff don't understand that SPD serves all the services within the facility, not just the OR. And we serve them all with equal importance as our customers. That's very true. We were responsible for L&D, cath lab, respiratory therapy, ICU, ER, in addition to the OR. And that is very true, that a lot of times that's not fully realized, that while, yes, there are surgical cases going on and that's our biggest customer, there's also smaller customers all throughout the hospital that need our attention and need our care, and we have to assemble those things just like we would for the OR. 100% of the 100% of the time, everyone needs perfect stuff, which unfortunately we're human and perfection's impossible, but we work as hard as we can to get there. And then Angus, it all comes down to communication and knowing that each department's not perfect, but as long as the leads and managers are constantly communicating, the relationship will improve. It's hard work, but well worth it. Absolutely. That goes back to the couple slides ago when I pointed out that, it's critical for the top of the departments to be fully invested in building that relationship and building those pathways of communication, because they're the, as the leaders, they're the ones setting the example. And if they're not communicating, it's difficult for the staff to communicate because, if the manager's not going to do it, why should I? So absolutely. I agree with that 100%. Teresa, that's so true. Angus. Yep. And then Pete. That has been included in the OR orientation in the past year at our facility. That's awesome. That was one of the things that we added, was they would at least come through and spend a couple days observing. I've seen, I don't know how many of you are part of the sterile processing professionals group on Facebook, but one of the recommendations I saw there was to have the OR staff work in decontam, which honestly that might scare them out of the hospital. But yeah, decontam's definitely something else right there. But that's great. Having staff at least get that exposure to each department, I think is as I've said repeatedly now, is key to building that relationship. So we're continuing our methods here. Develop, if possible, teams. I think, working at Censis, we have teams for all kinds of stuff, and having those teams and having that group of people that I can collaborate with and work with, it's made me a better employee, number one. Number two, it gives you a focus group of people that are working on the same project, same kind of knowledge and experience. But in addition to that, knowledge and experience from other parts of the company, other parts of, the OR and SPD departments, having those teams that are focused on critical inventory and services, with staff from all the areas working together, that allows you, I lost my train of thought. Hang on. That allows you to, it left my brain. I saw Pete say we're building a list of AKAs, and I was like, what's an AKA? And then it just disappeared. Anyway, so building that team, to focus on specific critical inventory and services from staff from both departments. It's a really useful tool because it allows a consistent way to collaborate and a consistent group of people to communicate with, people that are familiar with their specialty, but also have experience from other areas of the department. And here again, we're talking about the Ironman team. So like I kind of mentioned earlier, we had staff from both departments. We had managers, we had the directors, and then me, little old me. So a little more detail on that. So when I arrived on shift, I went to the rooms, and, I'd go in, hey, Dr. Pfeiffer, everything good today? Any issues? And, if there was something with the count sheet, there was an issue with the tray, I could take that back immediately and say, hey, this happened. We need to make sure it doesn't happen again. If there was a count sheet, as the database administrator for our tracking system, I was able to go modify it so that on his next case, he had exactly what he needed. And then, we had weekly meetings where we went and sat in the conference room and discussed what went on during the week, any major issues, any smaller issues that we saw popping up repeatedly, and how to fix that, keep those from happening over and over again. Because, honestly, the big issues are big issues, and they're terrible to deal with. But a lot of times they get fixed immediately because they're big issues. When you have those little tiny, like, this set, every time I open it, I have to go get this peel pack. If I'm the surgeon, I'm having to ask for that every single time. After a while, it's like, really? Come on, guys, put the peel pack in the tray. Those little issues, the little rock in your pebble, or not rock in your pebble, pebble in your shoe, over time, those balloon into those big, giant issues. And a lot of times, because they've been going on for so long, in my experience, by the time we get to dealing with the small issues, they're bigger than the big issues were. So having something like this, where we had, in this case, me, going from room to room, finding those small issues before they became big issues, we were able to avoid all that. And then having those weekly meetings with not just the staff that were, in the rooms and in SPD, but also the staff, the manager and director level staff, we were able to get their assistance on things that we couldn't address directly. So that's another key thing is when you build those teams, you've got to have time for them to sit down and discuss. I know Derek's in here. We have a scrum every day at 3:00 where we talk about things that have gone on throughout the day, any issues that we have, and how we can fix them. And it's been really cool to see. And this happened when I was at Memorial Hermann. It's really neat to see the team put their heads together when someone encounters an issue that they need help with, and see all that knowledge. What's the word I'm looking for? Converge on the problem, and a lot of times just boom, it's fixed right then and there within minutes. So building those teams, having those staff that are specialized into different roles in addition. And when I say specialization, I don't mean specialization like this is all that they do. I mean, they have their regular job, but they also have a specialization that they, if you have an issue with this type of thing and you can't get help from your coworkers or whatever, you can go to this person and know that they have advanced knowledge in this topic or service or whatever. So teams is great. That's really the point of this whole thing. Let's see what we got here. As an OR nurse, Rebecca, as an OR nurse, I've worked in decontam and assembly, and it is complicated work. It is. Decontam, like I said earlier, decontam is something else. Patty, I did that where I came from in Memphis. If the OR staff continued to send down dirty, disgusting carts, they were required to go to decontam and reprocess their own cart under supervision, of course. That's a unique punishment that I haven't heard before, but I'm sure that it got the point across. One of the things that we've done here in Houston at a couple of my hospitals is they've developed a compliance system where they use the tracking system in decontam to log how they're receiving case carts, and they have a team of SPD, OR, and managerial staff that meets once a month to review these compliance logs and make changes to make sure that they're hitting the best practices as recommended by Amy for sending surgical instrumentation back from the OR to decontam. And that has helped them, I know, tremendously. I wish they'd done it when I was there, because there's nothing like getting a C-section set that's been sitting in a case cart dry all day. I'm sure all of you in the group chat and in the presentation can relate to that. Then let's see. Good job rounding on surgeons. Need more of that. It's really cool, and it goes back to putting a face to the name. It gives the doctors, a familiar person to, a person that they're familiar with, that when, they see you in the hall or whatever, they say, hey, and if I think it makes them more comfortable. Not that surgeons are ever, I think, really uncomfortable with asking for things, but, when they see that same person and they see him in the hall and they're like, oh, hey, by the way, I needed this, it helps them get what they need, I think, a little more efficiently. Our SPD feels uneasy rounding. The benefits are huge. I think one thing, at least for me, that helped me not feel that way when I got asked to go into the OR rooms, because it is definitely intimidating to walk into a room if you've never done it. Put on a mask and there's all these people standing in there. You don't want to touch things you're not supposed to touch. Stuff like that. One of the things that I put in my head was just, the surgeons and the staff in there, we're all people, and we're all here with a common goal to help our patients. And, when you look at it that way and you approach it from the idea that they're not coming to work looking for a reason to yell at me about stuff, and, going in there and asking questions, like I said, fixing the problems before they become big problems. I never encountered a doctor or any staff in the OR that didn't appreciate that. And we appreciate, I always appreciated it as an SPD tech when someone came to me and said, hey, this is happening. We need to fix it before it blows up. It's always better to do that sooner rather than later. So, just, I think, encouraging the SPD team to recognize that we're all in this together. Going into the OR isn't presenting an opportunity for you to get in trouble for anything, get yelled at for anything. It's a way for all of us to collaborate and solve problems. I think that might ease some of the tension about going into the OR. Plus, it's really cool. And then, yeah, like Kevin said, that's a great point. If you have people that are comfortable, take the ones that aren't comfortable. Give them a buddy, help them get their feet wet. Short staffing, always a always a challenge. There's Derek chiming in. That's the beauty of a team. Leader doesn't always have the answer. We rely on expertise around us to solve issues. That's exactly right. Oh, and Teresa, that's a great point. Communicating with each other so you don't have three people or more asking the same question. If they would have communicated, all would have had the answer at one time. It's very true. We came across that, and that's one of the reasons we created the liaison position, so that we had someone focused on getting the questions from the OR or getting questions from SPD and communicating those things, so that one person was doing the communicating, one person was doing the receiving, and then disseminating that information. Because we had the same thing. We'd have someone come in, hey, I need this set for this case. All right, we're on it. And then someone would come in from the same case, hey, I need that set. And it wastes everyone's time when you have the same people asking the same questions. So building those liaison positions, I think is key to that. Not a punishment, help foster understanding of each department's workflows and needs. Yeah, that's true. I didn't mean that like literally a punishment. That's probably a poor choice of words, but it is really great for relationship building. They only had to do it once, and they have a new respect for SPD techs. That's how, Deacon Tan will do that. But yeah, that like I said, that at the very beginning, that was one of the things that we struggled with the most. Was we had staff that didn't think what we did was difficult, didn't think what we did required a lot of knowledge. And, I've been writing letters to Congress here in Texas, asking them to to create an initiative to make SPD not just a certification, turn it into a post-secondary education program, like so many, OR, surgical technician, nurses, things like that, something similar to that, because it's work it's just as important. But I think SPD techs, at least for me, I felt like because I only had a certification, I didn't have the same ability to ask questions and question things that I would have had if I had had like a bachelor's degree or associate's degree or something like that. That's something I've been bothering our congressmen in Texas about repeatedly. We have meetings every morning discussing issues, but they don't communicate what they found out about those issues in question. Oh, hang on, I skipped this one. My team's embracing teams. How do I get OR to buy into teams? They feel their day is done and they want to go home, or worse, management does not give them time to get together with their SPD team counterpart. So first, I think the key there is to get management in both departments bought in. Second, for me, when I train in the OR on our tracking system, I have something. My little catchphrase that I tell them all the time is, trying to get them to scan instrumentation is take these 30 seconds, scan this item, you'll save yourself 30 minutes later. Getting them to buy into that is just repeatedly bringing it up, repeatedly driving it home, and then demonstrating that if my department works like this, we can do this for you. So if you'll work like this, you can do this for us, and we can all work together. And demonstrating and showing them the benefits from just one side of the equation, I think will, at least in my experience, it's tended to push the OR into, okay, we're in. So I hope that helps. And then Teresa, we have meetings every morning discussing issues, but they don't communicate what they found out about those issues in question. We did and didn't. So it depended. If it was something that the department as a whole needed to work on, or something that needed to be addressed, or I change it, Vincent, I need you to change this count sheet, that kind of stuff we shared with the whole department. Sometimes there was more targeted communication and coaching with just a couple staff. So it could be something like that. But if there are issues and they're never being communicated, that's definitely a problem. And that goes back to what I said. You've got to get buy-in from everybody. It's harder to complain when you have a face to the name instead of a nameless, faceless voice over the phone. Absolutely, 100%. For me, what I always did when someone called me, if it was instead of if I had the time and the opportunity, instead of saying, oh, it's over here, I would just walk over there and meet that person and say, oh, it's over here, let me show you where it is. That way, you got a chance for them to meet me, put my face to the name, and it was a chance for me to also see that person. Understanding, accepting our roles has to happen. Focus on doing our part first. Yeah, that's true. I also saw Mary chime in. It's not a we, they message, it's a united message, 100%. And I'm guilty of this right now during this presentation. There's we and they. At the end of the day, it's us in surgical services, perioperative services. It's all of us serving the patients. So that is the bottom line. Create the liaison positions. We had one too, and it was great. It really is. Giving the OR a safe, clean, functional set of instruments will earn SPD respect. That has to be the first priority, definitely. But at the same time, like some others in the group chat have alluded to, the OR has a responsibility to, help meet the needs of SPD so that you can give them a clean set of functional instruments. Like Patty was saying, getting a case cart full of dirty, mixed up stuff, it makes it difficult for us in SPD to do our jobs. So, it goes back to, like what Mary just said, it's a united thing. One affects the other. Everyone's got to be invested and involved to get the optimal outcome for patients. And like Kevin said, point of use cleaning, absolutely. Okay, we were just on that one. I clicked the wrong button. So we're reaching the end here, which is going to leave us, 20, 30 minutes to I've got some questions and answers that I see coming in. But, in summary, as we said at the beginning, those negative relationships have a damaging effect on collaboration. It's hard on the team. It makes it difficult to come to work. And I've experienced that firsthand, and it's not something that I would want anyone to have to deal with. On the other side of the coin, you've got, when you have that positive relationship, the good lines of communication, everyone's invested. That's when, each department is able to be the best that it can be. And that's when you provide the best patient outcome. So in short, we're all better when we work together. Teamwork makes the dream work, as the common phrase goes. So from there, I don't know, that's in there twice. We'll open it up to some questions. I'm going to read a couple more things. And I saw a couple things come in the group chat. Our SPS and OR is always arguing about who's doing what. For example, instruments supposed to be placed in a certain area, and SPS is supposed to go to that area and pick them up, but they blame each other for that not happening. Well, as managerial staff, you have access, assuming you have a tracking system, you have access to a ton of data at your fingertips, and using that data to enforce compliance, while can be difficult and it can be upsetting to people sometimes, that's one of the uses of that data, and enforcing compliance and making sure that everyone's working together is critical to use that for. So, perhaps that's something that you could use. So I've got some questions here in the questions and answers section. The first one's from William Whitmore at Seattle Children's Hospital. I've always felt like SPD should let putting up clean, safe, functional instruments should be our primary objective. Won't doing that bring instant respect? It does, absolutely. But like I kind of alluded to earlier, because both departments depend on each other. While you can do you can do those things in SPD, but you also need your counterparts to do their part as well. So, having people having people from both departments collaborate and look at, okay, well, you guys need this from us, we need this from you. We can, if we can both meet these goals and meet these objectives, then we can work together to get clean, safe, functional instruments up for everybody. Next, we had Jan Prudent from EIRMC. In our hospital, we do daily follow-up with every cart that comes back to decontam. Any follow-up to non-compliance is emailed to leadership to do education and process improvement. Our C-suite has our back. That's awesome. I'm not really sure when I worked at my hospital, I wasn't really sure that the C-suite actually knew who we were for the most part, other than just the data and numbers coming from the department. I'm sure they did. But that's really great. And I'm sure that took a lot of work to get into place, because I imagine that there's probably a lot of carts coming in your decontam. But I think it's awesome that y'all are able to, enforce compliance that way, and you have leadership backing you 100%. Like I've said all along, that's the key. And then another one from Jan at EIRMC. We've worked with our state community college, and they're trialing CS courses certification as a prerequisite to surgical tech. That's really cool. That's one of the things I've noticed here in Texas as I've been to my various Houston hospitals is I see more and more of our community colleges doing clinicals, doing work at the hospital before they just jump in as a CS tech. Like I said at the beginning, I came from the kitchen and I just kind of jumped into sterile processing. And then when I came to Memorial Hermann and got my certification, I had already been working there. So it was just, here's a self-study course, go learn and take the exam. So I think having that experience beforehand, before and one of the important thing, or not important, but one of the key things that I see our community colleges in Texas doing in Houston is they send the students to different hospitals. So you get a wider range of, okay, well, I worked here, and you get that experience of different environments, different leadership structures, different, just differences in the way all the departments work. And I think when you have that and then you settle at a hospital to start your career, that extra experience you bring in is really beneficial. So then we have Archie from Hart Hospital. Someone who's been in the field for 30 years, worked trauma center and surgery centers, open 2 hospital for SPD. You're doing a great job. Not a question, just, I appreciate the compliment, Archie. Thanks. Then let's see. I saw a bunch of stuff coming in the group chat. William W., the whole issue of you did this, and instead of saying let's do this to fix it, we can't say, well, you did this. Both sides making sure they're doing their part will make it easier to bridge the gap, I think. Yes, you said that better than I did. And like I said, I'm guilty even during this presentation of we and them. It's like Mary said earlier, it should be us. And instead of blaming and pointing fingers, it's how can we work together to get this done and get this fixed so that we're providing the best care and best outcomes for our patients. So that's a great point, William, and I think you hit that on the head better than me. Shauna C., for SPD teams that are primarily from other countries and English is not a first language, how can we help them study and fully understand the guidelines in getting certified? They only offer CRCST exams in Spanish and English. Honestly, I'm not sure. I've never run into that. I was not aware that they only offered that test in Spanish and English. If that's the case, that's kind of disheartening. Like, there's surgery happening all over the world. We need as many people certified and educated as possible. I would go ahead, Lisa.
Oh, I was just going to let you know that we got a lot of questions in the question and answer area.
Oh, so, where did they move to? Oh, questions for N. Okay, yeah, my bad. I missed that folder.
I'm going to go ahead and moderate those whenever you're ready.
Okay. Anyway, my suggestion there would be, if you have anyone in your department that can maybe translate or work with those people in their native language, I think that's probably the best bet at this point, unfortunately. William, again, interdepartmental daily huddles have been huge for our OR SPD relationships. That's definitely true. One of the things we did just in SPD was we started a huddle. We had some people that had a lot of experience, like 20, 30 years experience. And they were able to kind of push those huddles and lead them and show the rest of us that had not had as much experience. For this kind of case, you're going to need this kind of instrumentation. And us sitting down every day during shift change and learning how to prioritize and how to identify what cases needed what instrumentation was really helpful. And then pushing that into a huddle with the OR. it demonstrates interdepartmental knowledge between everybody. Everyone gets on the same page. And like we've said all along, optimal patient outcomes come from that. So that's great. Rebecca says, I'm not sure executive management realizes the importance of the SPS department. Their pay scale does not reflect the importance of the department that the department has on the entire hospital. That's unfortunately regarding pay scale. I think that's the case in a lot of places. It's definitely something I ran into here in Texas. It's one of the reasons I've been harassing my legislators, because I think having the CRCST become like an associate's or bachelor's degree, a post-secondary education degree and or certification, I think that would kind of what's the word? It would kind of like validate it as something that's more difficult to obtain, and the people that are doing it, they're really devoted to their work and invested and help bring the pay scale more in line with the work and the skills required to do the job effectively. The same as our Department of Supply Chain, when we are the ones that keep the hospital running. I think, honestly, we haven't really talked about supply chain, but supply chain is just as important as the other two. I could never reprocess or process soft goods. So, without supply chain, we're missing half the case. So, got to have them as well. And then Teresa, the veterans are the most important and the reason why we're here to take care of them. Absolutely. Tricia said every day, 3 times a day, we have a huddle with staff. We have a list of reprocessing items we write out as cases are set and things are missing. We communicate if items have never been have been processed and or came back sterile, just to keep everyone down and SPD knowledgeable. That's awesome. And from there, if you're doing that and you're seeing over and over that things are being processed and then being sent back sterile, that's an opportunity to streamline your preference cards so that you're not doing a bunch of extra work. So thanks, William. I'm glad you enjoyed. Glad you got something out of it. And then Lisa, we can hit the questions in the questions in the folder.
Okay, excellent. So there were quite a few questions that had to do with you explaining more about your experience. So one of them was, can you elaborate on the job duties of the liaison?
Yeah. So I, like I said, for me, I think I was more of kind of a specialized liaison in that I was going room to room and actually working with the surgeons. But we at the hospitals I go to now, the liaison role that they've developed, they have specific staff identified as, okay, if an OR staff member needs something, instead of coming into SPD and just finding the first person and asking them, hey, we need this turned over, we need this, whatever, you go to your liaisons, and it's up to the liaison to coordinate the entire team, make sure that, what the OR is asking for is being taken care of. And it just gives them a point contact. And some, I would say you should have probably, 2 or 3 in case someone's gone. But it gives them a point of contact that's consistent and that they, it lets you develop trust between, okay, if I go talk to this person, they're going to make sure it gets done. And same thing from SPD. If you have an OR liaison, that you can go to that person and talk to them, and they'll communicate that information back to the people that need it. So that's really the point of a liaison, is not that their job duties are so much different than a regular SPD technician or OR team member, just that they have the additional responsibility of being there for people to come to when things are needed, and then being able to disseminate that information effectively. And like Shauna said in the group chat, navigator is a great word for it. You're navigating the needs and making sure they're taken care of.
So along the same lines as the last question, someone was curious to know, is the liaison a surgical tech or a nurse or a sterile processing technician?
For us in SPD, it was a sterile it was like a tech 3. I was a tech 3, so I got put in that position as well. But in SPD, it's typically an SPD tech. In the ORs that I've been to where they have liaisons, I've seen surgical technicians and I've seen nurses do it. So I don't think there's necessarily consistency about if it's one type of staff over another. I think the key there is just to make sure that whoever you put in that position has the necessary experience and good communication and leadership skills so that they can drive their team to get done what needs to get done.
And another question was, did you make the cross training mandatory or was it voluntary?
For us, it was voluntary. I would have preferred that it be mandatory because, like I said, I think seeing how each department works and the specific hurdles and things that they have to deal with, I think helps build that respect that we've been talking about between the two departments. Really unifies them together as an us. But even starting it voluntary and then it gives you a chance to kind of see the benefits that you get from it, and then I would encourage hospitals that have made it voluntary to make it mandatory. I think it should be. I think it should be everywhere, but that's just my personal opinion. And then there were some questions about should each department have a liaison navigator to communicate with one another? I think so. It kind of, it's like a tree, right? You have all the leaves up top, you have the roots down below. So, you have SPD as the roots, you've got OR as the leaves. There's one trunk between them, and that trunk is your liaisons, and it gives communication a dedicated pathway to flow. Like someone else alluded to in the group chat, it keeps you from getting the same question repeatedly, and it gives the liaisons in each area another person to go talk to make sure that the information that they need to share gets properly spread out to the people that need it so that they can get what they need done. So
another question was, how do you combat short staffing in sterile processing and then have to explain to the OR that you are short staffed?
Short staffing seems to be a chronic problem everywhere I go, everywhere I've worked. One of my hospitals is doing, they work really closely with their business intelligence, and what they do is they use the productivity data from their tracking system to demonstrate, this is what we're doing. This is the stuff we're turning over. This is how many instruments and inventory items our staff are doing. And they've developed a formula that gives them a specific number of full-time employees, and that's been effective for them. It's definitely cut back on the amount that they're short-staffed. They're still a little short-staffed, but instead of being short-staffed by like 20 people, they're only short-staffed by like 6 now. So I think that's one thing you can do is make use of all the data that's in your tracking system. Finance people, they're numbers oriented. They like to see pieces of paper with numbers on it. Any evidence that you can back up with data is more likely to get their attention and get what you need than if you're just going and making your case verbally. Having those reports and that data is key. And then William said, if you don't present the compensation staff with numbers that show your productivity and where it's lacking due to being short staff, you'll never get more you'll never get more FTEs. Exactly. That's the point I was just making. You've got to have those numbers. And it's I can almost guarantee you it's in your tracking system. So, make it, as we've advanced into the 2020s, we're more connected than ever. There's more data than ever before. So making use of that data to get what you need is definitely a key. And that's what Kevin just said as well.
Excellent. And somebody asked, what can I start doing right now to increase camaraderie between the OR and SPD?
So one of the first things we did was, when I first started there, we had our like weekly staff meetings were like siloed together. It was us and SPD and them in the OR, and we had our staff meetings, but we never really had a meeting together. So that was the very first thing that we did was, if we're having staff meetings, at the same time, on the same day, we should just have our staff meetings together. Everyone can meet in the OR lounge. We can have donuts. And that gives us an opportunity to not only address the needs of each department individually, but the needs of the surgical services team as a whole. And, it goes back to what we've been saying. It lets you put a face to the name. It lets you meet your coworkers and get to know them a little bit. And, as people in the group chat have alluded to, it reduces the amount of it reduces the odds of someone, abusing someone over the phone and things like that. So that was one of the first things we did. And that was really the key to getting all this stuff rolling was just, realizing, we should just put our departments together instead of treating us like completely separate, siloed groups.
And here's another interesting question. I see where improvements could be made when handoffs occur from SPD to OR, but I'm unsure how to present my thoughts to my leadership team. Based on your experience, how have you handled taking change management ideas to your leadership team?
So what I always did was, and this is honestly how I got into doing the tracking system database was, when I would process count sheets and I would see opportunities to, we could streamline this, we could standardize this, we could make this process better. I would thanks, Kevin. Have a great Thursday. I would make notes, and like I've said, people love to see things on pieces of paper that back up what you're saying. So I would make notes. I'd notate specific examples of, if we did this, I think it would potentially save us this amount of time. It would let us do this. We could streamline this, and then taking that to my management team, and eventually to the OR teams that I was a part of. It helped them form, like, in their head, okay, well, if we do this, then yeah, I see where you're coming from. That's a good idea. We can implement it. So I think just starting there, if you have a change and you want to talk to your supervisor about it, making notes and being able to go in and have a little mini presentation about why you think what you want to do would be beneficial. I think that's a great way to get that started.
And somebody asked, how can I foster communication? So,
like I said in one of the previous questions, I think getting the departments together for different things, I think that's critical. If you're having meetings at the same time, you're having huddles at the same time, exchange staff between the huddles. So that you're starting to that helps you open the lines of communication. It helps people see what's going on in each department. It helps people understand the hurdles and challenges in each area. Thanks, Teresa. I'm glad this was beneficial for you. Have a great Thursday. So just getting started is just as simple as getting the departments together for staff meetings.
For someone who's new in their position to either SPD or OR, what are some initial things that they can do to learn how these two teams work together?
I've said that, we had the opportunity to go watch cases. That came about just because we were slow one day, and I asked if I could go watch a case, and they were like, "Well, yeah, if you're slow, you don't have anything to do, go learn something." And I think as a new technician, asking those questions and taking the time to sit down with staff that have been at that facility or have been in SPD for a long time and kind of picking their brains a little bit, and really, letting them show you stuff. I think as people, it's difficult sometimes to recognize that there's things that we can learn from others. I think it's one of the human conditions is just, I think we're kind of hardwired to say, oh, I know that already. I don't need that extra information. And one of the things that I've tried to teach my 12-year-old, who, of course, 12-year-olds, they do know everything apparently, is that when you shut that part of your mind off and you stop learning, that's when you stop growing. And even as she says, as an old man like myself, there's still stuff that I can learn from everybody. And being open to that and just sitting down, picking people's brains, asking questions, that's how you can you can really get yourself going as a new employee and a new person to the field.
I think that engagement is so important.
Absolutely.
Someone asked.
Hang on, real
ahead.
quick. And let me say this too. You know, the surgeons that, you know, when I would go into the rooms and I would watch cases or round, the surgeons were never unhappy to share what they know. I think when you've gone to school for that long and you've learned that amount of stuff and it's something you're really passionate about, you know, you want to share it. You know, it's like one of my side hustles that Grace knows about is photography, and I have studied that stuff extensively, and I love talking about it. I love getting in and having conversations about it, and that was what I found as an SPE tech. When I would talk to the surgeons and ask them questions and stuff, they loved sharing that, and they were never unhappy that I was there asking questions and wanting to know more about what they were doing. Thanks, Rajan. I hope I didn't butcher your name. Have a great Thursday. So sorry to cut you off, Lisa.
Oh, you're fine. So what projects did you implement to increase OR SPD productivity in the community in your work environment?
So the biggest one was the one I've talked about the most, the Ironman team. And, you know, like I said, we rounded and we talked to the surgeons. And from there, we began standardizing all of our inventory. And this is something that Memorial Hermann still does. I'm helping them with it now, even as a Censis employee. We started, what we did first was we went through all of the inventory in the database. We gave it a standardized name so that when someone referenced something, everyone knew what it was, because everything was called the same name, no matter what tray, no matter what, you know, what service, what specialty, it was the same, no matter where you found it. And that helped a lot too, because especially for new people in SPD, it's difficult sometimes when so many instruments have so many different names. So having those standardized descriptions and getting everyone on the same page is, you know, this is what we're going to call things. This is how we're going to reference these different items. It helps everyone, and it improves communication, because you're not, you know, if I call you on the phone and I say that I need this particular retractor and I use the nickname that we call it in the OR, and you're new, instead of just knowing what it is and being able to give it to me, you're going to have to very likely have to go ask someone in the department who's going to have to explain to you that, you know, it's actually this thing. And then you have to go get it and deliver it. And if there's a standardized set of names, a standardized set of conventions that everyone's adhering to, then you cut out all that extra stuff in the middle. So that was the biggest project we did. In addition to our various teams, you know, we had the ortho team, we had a team for CV, we had a team for plastics. Plastics is really big where I live out here. Deep flaps and that kind of stuff. So we had a team for that. And it fostered communication, and it made sure that it gave people an opportunity to kind of grow their knowledge and things they were interested in, and it made sure everyone had what they needed all the time.
Someone asked a question about how you handle bioburden. Do you have how do you know when to perform a corrective action or when just to continue to train and re-educate?
So I see the end of this too is like loaner trays. So for loaner trays specifically, the problem there is that they come in from, they're not yours. They're coming in from different hospitals. It's something that you have to train your staff that, you know, when they come in, they have to be inspected. You cannot take shortcuts, because you can't count on, you know, the hospital across the street to do the same job that you're doing. So that, you know, that's the thing with loaners. And then as far as correction and bioburden and stuff like that, where I worked, that was one of the things that would definitely get you let go, was putting up stuff with bioburden in it. Because if it's not clean, it's not sterile, as we all know. And everywhere that I worked, everywhere that I go, that's one of the things I hear about the most is, you know, we're counseling this person that, you know, they're going to get this right up, they're going to get this because of bioburden. So I don't know, you know, without knowing anything about your hospital, I don't know if 2 instances is appropriate or not. I think that's definitely something that, you know, the managerial teams need to collaborate on. I know there's some places that would say that's, zero tolerance, and there's other places that would say, well, it depends on the individual staff. So it's what's the number of instances I think will be unique to your hospital, but you do need to just continue to train and re-educate and go from there. That's the first thing, because people can't fix what they don't know is broken. Number one.
And also the supportive technologies that go along with being able to thoroughly inspect is probably a key component to that as well.
We had a borescope system. We had, for scopes, scopes often get bent and flexed, and it breaks the little light fibers on the inside. The OR was getting rid of one of their towers, so we were like, hey, can we just put that in our department? And we kept light cords hooked up to it so we could test our scopes. So yeah, making, like you said, Lisa, making use of the available hardware and technology you have to double check and triple check your instrumentation is definitely key.
This is not necessarily a question, but more a comment. Someone had said that they actually wrote certification into the job description so that they have a ladder to develop their staff.
Yeah, I saw Jan say that, and I meant to say something about it, and then I did not. But I've seen that more and more as I visit my accounts where certification is required. And if you don't have it, you have to get it within X number of days. And or if not that, then you can't advance past like Tech 1 without it. I think that's definitely something that's really important. Having those letters after your name. Number one, it always made me feel great to be able to put Vincent Sanchez CRCST. Number two, I think, at least for me, it made me more invested in my work than I already was, because I'm like, well, now I have a certification. I've got something that shows I know what I'm doing, and I want to prove it. So.
Well, it looks like we've answered all of the questions. We had someone who said happy CS week next week to everyone.
Oh, absolutely. Happy CS, SPS, SPD week to everyone in the attendee list. I'll be out visiting some hospitals next week and wishing them happy SPD week in person, some of my accounts. But definitely, it's SPD week was always really fun. We always had a lot of good stuff planned. So happy SPD week to everybody.
And I believe it's Surgical Technology Week this week.
Oh, yeah. Happy Surgical Technology Week. I forgot about that one. Yeah, absolutely. We need you guys just as much as we need SPD techs, and just as much as we need supply chain people. Is there a supply chain week? If not, there should be, because Amanda said it was last week. Well, happy belated Surgical Technology Week. Supply chain this week. Okay.
All right. Well, I want to thank Vincent and Censis Technologies for putting on this wonderful webinar, and for all of the work that everybody has contributed to the profession who is in attendance. And just thank you so much. And have a wonderful week. And we look forward to another Beyond Clean and Censis presentation.
Thanks, everybody. I hope this was helpful. Hope you learned something. And get out there and help our patients.